Now, continuing distal from proximal femur, we are talking about shaft of femur fractures now. Now, this is an X-ray of an adult patient with a shaft of femur fracture. This is also an X-ray of adult with a shaft of femur fracture. And in contrast, this is an X-ray of a child with a shaft of femur fracture. You can clearly see that the triradiate cartilage has not ossified still in the head of the femur and the growth plate, the proximal femur. Anyways, so the point I'm trying to make here is that fracture femur can occur in adults, can occur in children. Now, whenever there is a shaft of femur fracture, what happens to the proximal fragment in terms of displacement? Although we speak about displacements in terms of the distal fragment, sometimes they ask you MCQs in terms of the displacement of the proximal fragment. Now, what happens to the proximal fragment in terms of the displacement? You see, there is a strong muscular forces acting on the proximal fragment, and this is what causes the displacement. The displacement that you see in the proximal fragment is flexion, abduction, and external rotation. So there is flexion, abduction, and external rotation of the proximal fragment. A rare MCQ that was asked. Now you know how to answer it. Anyways, coming back to shaft of femur fracture, what are the MCQs that are asked here? You see, in trauma, there is nothing to understand here. There is a force and it is causing a fracture. We need to know what are the MCQs that they are asking to be able to answer the questions. Now, one MCQ that is asked is the classification of shaft of femur fracture. It is Winquist and Hansen. It's been asked once, I think, rarely. If you want to know, you know. If no, it's okay. The complications of shaft of femur fracture are stiffness of the knee, delayed union, and non-union. But the most dreaded complications that we are worried about are two. Number one, bleeding and fat embolism syndrome. I've told you pelvis fracture and shaft of femur fracture are fractures that cause exsanguinating amount of blood loss. For shaft of femur, you lose around 1 to 1.5 liter, and for pelvis fracture, you lose around 1.5 to 2 liters of blood. So please understand that these are, massive volumes of blood loss and can cause a lot of problems to the patient. The other dreaded complication of shaft of femur fracture, particularly in adults, is fat embolism syndrome. Now, what is fat embolism syndrome? Quickly understand what it is. You see, in adults, the medullary cavity, the bone marrow is replaced by fat, whereas in children, the medullary cavity still contains the bone marrow. So this is a unique feature that's seen in adults, not in children. So once there is a shaft of femur fracture, the fat globules from the medullary cavity escape out and get into the bloodstream, and this is what causes fat embolism syndrome. Now, this is what causes lipiduria, and the fat globules can be toxic and causes various problems. Now, what are the manifestations? Please understand this. Manifestations take time. It usually takes around 48 hours after the fracture. 48 hours after the fracture. Now, why is this important? Because there are certain keywords. Whenever you are attempting an MCQ exam, you should look for keywords, and this is one of those keywords. If you come across an MCQ which says a long bone fracture in an adult, following which around 24 to 48 hours, a patient comes to you with confusion, difficulty breathing, tachypnea, dyspnea, tachycardia, petechial rashes, they are talking about fat embolism syndrome. So fat embolism syndrome, usually after femur fracture, around 48 hours after the fracture, presents to you with respiratory, cutaneous, and central nervous system symptoms. So the keyword you're looking for is femur fracture in adult, followed by 48 hours later manifestations. Other similar MCQs will be there which have keywords. For example, massage. If the MCQ gives you massage history, say a child comes to you with a fracture on the elbow with a history of massage. What do you think? Supracondylar humerus fracture, history of massage, think myositis ossificans. Think myositis ossificans. If the question tells you pain on passive stretching following a fracture, pain on passive stretch is again a keyword for compartment syndrome. Similarly, femur fracture, difficulty breathing, 48 hours after the fracture, it's usually fat embolism syndrome. These are the keywords you should look for, and we'll talk about all of this. A few more MCQs. Long bone fractures in the lower limb, particularly femur fracture, can be temporarily stabilized with a Thomas splint. This is the image of Thomas splint. Other splint is a Bowler and Brown splint. We have read about the splints in the basics. You can go and review that if you want to. Now, what's the treatment of shaft of femur fracture? First, we'll address that. Then we'll talk more about fat embolism syndrome. Shaft of femur fracture management or treatment depends on the age of the patient. If the patient is very young, you can give Pavlik harness. Less than 6 months, Pavlik harness. 6 months to 5 years, you can give a hip spica cast. You can use gallows traction temporarily to stabilize the fracture, but please remember, it cannot be used in children who are more than 2 years or who weigh more than 12 kg. It can only be used in children less than 2 years and weigh less than 12 kg. I'll show you how. 5 to 10 years, if a child is 5 to 10 years, you use elastic nails, flexible nails. Enders is one variety. Titanium elastic nail is another variety. These are both flexible nails. And adults more than 10 years, I've told you, based on the algorithm of fracture management, it's a long bone fracture in the lower limb. The treatment would be close reduction, internal fixation with intramedullary interlocking nails or rods. You know this from the basics. Let me show you the images. This is the image of Pavlik harness, and this is the image of hip spica cast. Hip spica is basically a cast that immobilizes the hip as well as the spine. So hip immobilization with the help of spine. This is gallows traction. What you notice here is this is usually applied to children below 2 years who weigh less than 12 kg. And once you apply this, parents are very happy because the child will be very, very happy, and he will be revolving around there under the traction, and parents will be very happy. The thing you need to remember is that both the limbs are hung. Gallows means pasi, hanging, right? Take him to the gallows, send him to the gallows, right? So you hang both the limbs. You hang both the limbs, and this is what you can use to temporarily stabilize a fracture, make it sticky, and then you can put him on a hip spica cast or a Pavlik harness, whatever you require. Okay, this is your gallows traction. And elastic nails or flexible nails can be used in shaft femur fracture in pediatric age group. This is an X-ray of showing a titanium elastic nail system used for a shaft femur fracture in a child. And in adults, you can go for close reduction, internal fixation with intramedullary interlocking nail or rod. Interlocking means you're using these screws to interlock the nail so that it doesn't rotate. Now, before we proceed and talk about fat embolism syndrome, I want to talk about one old nail that we used to use. It was called Kunsher nail. Kunsher nail, it's an old nail, outdated. We don't use it anymore. It was only used for isthmus fracture. It could not have been used for segmental or comminuted fracture. It was only used for isthmus fracture. Now, what are the points that you need to remember here? Number one, its cross section was in the shape of a clover leaf. Clover leaf. The cross section was in the shape of a clover leaf. Number two, it was a straight nail. If you recall, femur anatomically is a curved bone. So you are putting a straight nail in a curved bone. What will happen? It will give you the classical 3-point fixation. It would give you a 3-point fixation to stabilize the fracture. It could only be used for isthmus fractures. It could only be used for isthmus fracture, not for comminuted or segmental fractures. And it had an eye to help extract it out. This eye of the nail was usually placed anterolaterally. Sometimes, very rarely, they used to ask questions from Kunsher nail. Nowadays, I have not seen any question. But just for the sake of completion, you should know what it is. Now, coming back to complications of shaft of femur fracture. Fat embolism syndrome. Now, what is the classical triad of fat embolism syndrome? Patient will have respiratory, neurological, and petechial symptoms. So, respiratory, neurological, and cutaneous symptoms. This is because the fat globules have escaped the medullary cavity, gotten into the bloodstream, and are causing the manifestations. Respiratory symptoms as in tachypnea, dyspnea, difficulty breathing, pneumonitis. Cutaneous symptoms as in petechial rashes, paraumbilical, axillary petechial rashes, classical petechial paraumbilical rashes. Neurological symptoms in terms of confusion, coma, right? Confusion or coma. And it is rare in children because in children, the shaft of femur or the long bones contains marrow rather than fat. We know this. Why is this important? Because usually polytrauma patients, they present you with these symptoms like respiratory symptoms and central nervous system symptoms, and they can be in ARDS. So you need to be able to differentiate ARDS from fat embolism syndrome to do the right treatment. Now, to help us get away from this confusion or solve this problem of the differential diagnosis of ARDS versus fat embolism syndrome, we have come up with a criteria known as Gertz criteria. You need to know this. There are major and minor criteria. Major are self-explanatory. It has symptoms of respiratory, CNS, and cutaneous. You can understand that there is nothing to memorize. But minor criteria are the one that students usually find confusion in, particularly patients who present to you with anemia and thrombocytopenia. So anemia and thrombocytopenia are parts of minor criteria. Also, fat globules in urine and sputum will be there. We have a test known as Gertz test that can help diagnose fat globules in urine. You use this criteria to make the diagnosis. Now, how will you treat fat embolism syndrome? Before treatment, I want you to understand that prevention is the best. Prevention is the best. So prevent fat embolism syndrome by early immobilization and fixation of the fracture. If in case it is not done, if it is delayed and fat embolism syndrome has started, then the only treatment that you can offer is supportive care. Supportive care. You can give ventilation also, but mostly supportive. Now, there are people who use dextran, people who use steroids, people who use heparins. All of these things are assumed to give some relief, but there is not enough substantial evidence for us to recommend something. So oxygen and supportive care is the standard treatment. Another thing I want to mention here is that if a patient presents to you with a femur fracture with fat embolism syndrome, it is ideal that you should not intervene then to fix the fracture definitively, because he's in a state of physical and physiological stress. That is where the damage control orthopedics aspect came into existence, right? I talked about that in our basics. Damage control orthopedics, the aim is to minimize the insult to the patient with surgery. You have to temporarily stabilize the fracture. With an external fixation. Send the patient to ICU to be stabilized completely. Once the patient is stabilized in the ICU, then you can do whatever you want. You can do a definitive treatment with a nail. So remember, a patient with a shaft femur fracture who comes to you with a fat embolism syndrome, you will not do close reduction internal fixation with intramedullary interlocking nail. Instead, go for an external fixator. Apply it, send him to the ICU, let the physician stabilize him. Once he's stabilized, then you can go for the definitive treatment. Now look at what this fracture is. This is an X-ray of the knee joint. AP view or lateral view? Yes, this is lateral view. This is femur. Yes, this is tibia. This is fibula. Very good. And this bone is patella. And you can clearly see that there is a transverse fracture of the patella with the proximal fragment moving or displacing proximally and distal fragment staying there. So there is a distraction in the fracture. Can you tell me why? Because if you recall, this is your femur, this is the patella, and this is the tibia, right? This is the fibula. If you recall, which muscle comes and inserts the proximal pole of patella? The quadriceps tendon. So whenever you have a patella fracture, the quadriceps tendon will pull the proximal fragment away. So there's a lot of distractive forces acting on the patella fracture, which will prevent its healing. So you know the treatment. Whenever there is a strong distractive force acting on the bone, preventing its healing, the treatment is to convert the distractive force into compressive force. Yes, you know this. Wait. Anyways, so patella fracture, X-rays are AP view, lateral view, one specialized view. Yes, skyline view. Skyline view is used to diagnose patella fracture. So the aim of the treatment of patella fracture is to convert the distractive forces into compressive forces. And what is the most wonderful device that does it for us? Tension band wiring. Yes. And how do you place it? By openly reducing the fracture and internally fixing it with 2K wires and stainless steel wire. So use 2K wires and stainless steel wire. That technique is known as open reduction internal fixation with tension band wiring. So tension band wiring is used for patella fracture. Where else will you use tension band wiring? Anywhere there is a strong force causing the distraction. Can you give me another example? Olecranon fracture. If you recall what happens in olecranon fracture, look at this. This is your olecranon. This is the humerus. Which muscle then comes and inserts at the tip of the olecranon? Let me give you hints. Hamstring, quadriceps, gastrocnemius, triceps. Yes, it's triceps. Yes, triceps inserts here. So if you have a fracture of the olecranon, what will happen? The triceps will cause distraction of the fracture fragment, preventing its healing. So we need to convert the distractive forces into compressive forces. What will you use? Tension band wiring. You'll use tension band wiring. So this is an image showing you olecranon fracture. Now sometimes patella fracture is an undisplaced fracture with no extension lag. That can be managed conservatively if you want to. And there was an MCQ that was asked. You use a POP cast. Which cast will you use? You will use a cylinder or a tube cast. Okay, you'll use a cylinder or a tube cast, where you apply the POP cast like a tube or a cylinder. That is known as a cylinder or a tube cast. Now the next fracture is bumper fracture. If you recall what bumper fracture is, the car's bumper comes and hits you. You're walking on the road, car's bumper comes and hits you. Where will the car's bumper hit you? On the lateral side of the leg or the medial side of the leg? Where will the car hit you? On the lateral side of the leg. The car will hit you on the lateral side of the leg. So your lateral tibial condyle will fracture. When the lateral tibial condyle fractures, that is called bumper fracture. Now, if you want to go into the details of the mechanism, the details are very straightforward. So look at this. This is the lateral condyle of the tibia. This is where the car comes and hits you. When the car comes and hits you like this, what happens? You're already standing, so there is axial loading of the tibia. Now it is going into valgus. So there is axial loading and valgus force. So this axial loading and valgus force is what causes the lateral condyle tibia to fracture. So what is the mechanism of injury? Axial loading with valgus force. So intra-articular fracture, and I've told you what is the treatment of intra-articular fractures: open reduction, internal fixation with plates. So you can clearly see here the force causing the bumper fracture is valgus force with axial loading. Right. Now what is this fracture? Classically, X-ray hai, leg, AP and lateral view. You can see tibia and fibula. This is the fracture of both bones of the leg, mostly tibia. Now tibia fracture, what is the treatment? Remember, recall from basics. Extra-articular, lower limb, long bone fracture, close reduction, internal fixation with intramedullary interlocking nail or rod. Right. Conservatively, if you want to, you can manage it with PTB cast. PTB cast, very, very important. It's called patella tendon bearing cast. Most of the students get confused the moment they see patella. They see patella, they mark patella. MCQ was asked directly, patella tendon bearing cast is used for. The answer is not patella, it's tibia. What is the cast for patella? It is cylinder or tube cast. Okay. Now what is the definitive treatment for tibia fracture? Close reduction, internal fixation with intramedullary interlocking nail. Right. That is what we have done here. Recall what is runner's fracture? A runner's fracture is a stress fracture of the fibula. Stress fracture of the fibula. Okay. Coming to ankle anatomy, quickly review ankle anatomy. What are the X-ray views you use for ankle? You use AP view, you use lateral view, and you also use mortise view. Mortise view. Clearly it will show you the ankle. Right? Clearly it will show you the ankle. So you can clearly see here in AP view that this is the tibia and this bone is the fibula. And this bone is the talus. This part of the tibia is known as medial malleolus and this part is known as the lateral malleolus. Okay. So in lateral view, you can again appreciate here, this is the tibia and the overlapped bone behind it is fibula. And this is the talus. This is the calcaneum. Right. And in lateral view, you will notice posterior malleolus. Posterior malleolus is a part of tibia. Now in mortise view, again you can clearly see the ankle joint. This is the medial malleolus, lateral malleolus, talus, tibia and fibula. Now what are the fractures that occur around the ankle? You can get a lateral malleolus fracture, isolated lateral malleolus fracture. You can get an isolated medial malleolus fracture. You can get a combination of both lateral malleolus as well as medial malleolus fracture. This is known as bimalleolar fracture. The other name for it is Pott's fracture. All of these are your eponymous fractures. Straightforward MCQs will come from this. You can also get a trimalleolar fracture where medial, lateral as well as posterior malleoli fracture. All of them fracture. This is known as Cotton's fracture. This is known as Cotton's fracture. Now before we proceed further, I want you to understand that at the distal end of the tibia, and the distal end of the fibula, this is the talus. There is a ligament here that articulates the tibia with the fibula. Basically helps maintain the syndesmosis. This ligament is known as antero-inferior tibio-fibular ligament. Okay? This is known as antero-inferior tibio-fibular ligament. It is attached to the tibia and the fibula on certain bony ridges. The bony ridge on the tibia is known as Tillot's caput tubercle. The bony ridge on the fibula is known as Lefort-Wagstaffy tubercle. Lefort-Wagstaffy tubercle. Now, upon forces acting on the ankle causing its injury, following things can happen. The AITFL, that is antero-inferior tibio-fibular ligament, can get torn in the substance. One thing can happen. It can get avulsed from the tibial tubercle, that is Tillot's caput tubercle, or it can get avulsed from the fibular tubercle, that is known as Lefort-Wagstaffy tubercle. If it gets avulsed from the tibial tubercle, we call it Tillot's caput fracture. If it gets avulsed from the Lefort-Wagstaffy tubercle, you call it Lefort-Wagstaffy fracture. That is all you need to know. Take care. Now, while you are on the subject of ankle injuries, I'm sure all of you have injured your ankle at least once. How? By spraining your ankle. And when we sprain our ankle, it goes into inversion. And when it goes into inversion, the lateral ligaments are the ones that are stretched. Very rarely, it can go into eversion also, and then the medial ligaments will get stretched. the medial ligaments, the deltoid ligaments will get stretched, but that rarely happens. All of us have, yes, think hard, all of us have at least once in our life injured our ankle by spraining it. And when we sprain it, we injure our lateral ligaments, particularly the most commonly injured ligament is anterior talofibular. That was tibiofibular. Here we were talking about tibiofibular. This is talofibular. Anterior talofibular ligament is the most commonly injured ligament in the body. Everybody has injured it at least once. Okay, it is this ligament. Anterior talofibular ligament is the most commonly injured ligament in the body. Now, whenever a patient comes to you with ankle sprain, you must see this. They come to your casualty, they may come to your OPD, and they will ask for x-rays because they will think it's a fracture. But please understand that x-rays are radiation and they are not to be given unnecessarily. Okay, don't waste resources. We need to conserve them. So what has Ottawa is a city in Canada. The hospital over there have come up with something known as Ottawa ankle rules. What they say is that there is no need to get every x-ray for every ankle injury. So there are certain criteria that you should look for in order to get an x-ray, because only then you might be expecting a fracture. Otherwise, just an ankle sprain, because ankle sprain is a very common thing that can happen. So what are the things that you should look for? Look for bony tenderness, either on the lateral malleolus or medial malleolus. If any one of them is there, get an x-ray. Or if the patient is unable to bear weight immediately following the fall, unable to walk on it. If the patient is unable to walk, if the patient has medial malleolus tenderness, if the patient has lateral malleolus tenderness, only then you should go for x-ray. Otherwise, there is no need for x-ray. It is usually an ankle sprain. Now, after Ottawa ankle rules, they have come up with cervical spine rules and so many other rules that can basically help people minimize the unnecessary expenditure on radiation. Anyways, moving further, coming to pilon fracture or plafond fractures. Now, what is pilon or plafond? Basically, pilon is a French word for ceiling. So ankle's ceiling is this part. What is this part? This is the distal end of the tibia. This is assumed to be the ceiling of the ankle. Now, this is a fracture that can occur if there is a axial loading or if there is a fall from height. When there is a fall from height, the talus will force itself into the ceiling, that is the distal end of the tibia, and cause fractures. So look at this x-ray. You can clearly see that the distal end of the tibia is comminuted here. And let me show you this 3D CT of pilon fracture. You can clearly see that it is comminuted. Everything is destroyed. This is known as pilon or plafond fracture. Right? Now, moving on. Calcaneum fractures. This is clear. Calcaneum fractures usually occur because of fall from height. This is the most commonly fractured tarsal bone. There are two MCQs here. Most commonly fractured tarsal bone is calcaneum. Most commonly dislocated tarsal bone is talus. Anyways, calcaneum fractures fall from height. There are two angles here. A lot of MCQs come from that. Bowler's angle and Gisant's angle. In calcaneum fracture, Bowler angle is decreased and Gisant's angle is increased. That's all you need to know about calcaneum fractures. Next fracture is Lover's fracture. What is Lover's fracture? It's a combination of fracture of calcaneum, usually bilaterally, with vertebral compression fracture. Obviously, it will be seen in patients who fall from height and landing on feet. Fall from height, land on feet. So this is known as Lover's or Lowery's fracture. Not to be confused with Jumper's fracture, which is a fracture of the sacrum. Okay, so Lover's fracture is bilateral calcaneum with vertebral compression fracture, and Jumper's fracture is fracture of the sacrum in the shape of a U or H. We have discussed that. Okay, now moving on to talus fracture. A very common talus fracture is aviatrix fracture. What is aviatrix fracture? It's the fracture of the neck of the talus. So this is a CT scan image showing you the body of the talus, neck of the talus, and the head of the talus. Now, the first thing you need to know is the blood supply of the talus. So let me draw this. Head, neck, body of the talus. This is tibia. What is the blood supply of the talus? If you recall, dorsalis pedis artery. This is dorsalis pedis artery and gives out a sinus tarsi branch which goes retrograde. So if you have a fracture of the neck of the talus, which part will go into avascular necrosis? Body will go into avascular necrosis. This is known as aviatrix fracture, the fracture of the talar neck. Why is it called aviatrix fracture? What's the story here, friends? Aviator is a pilot. Aviator is a pilot, and pilots, if the plane were to crash, they would jump out and they'll use a parachute to land. Even though they would use a parachute to land, they will land with a significant force. And these pilots who landed with a significant force ended up with talus fracture. So many pilots with talus fracture, they got the name aviator's fracture. Most common complications are avian and subtalar arthritis. Okay, now the diagnosis of avascular necrosis of talus is an MRI based diagnosis because MRI picks up avascular necrosis early. But in early days where MRI was not invented, they used to rely on X-rays to make that diagnosis. That is something where we are introducing you to an MCQ now. Hawkins sign. What is Hawkins sign? Now, Hawkins sign is basically subchondral lucency. And what does it suggest? It suggests viability. You remember when blood reaches the bone, the density decreases because blood is coming to the bone. And what are the characteristics of a dead bone? If you recall, dead bone is a dense bone. Dead bone is a dense bone, white bone. Dead bone is a dense bone, white bone. Why is it dense and white? Because there is no blood. There is no hyperemia. There is no turnover. There is no resorption of the bone because it's a dead bone. A live bone is a lucent bone. Live bone is a lucent bone, right? So whenever there was a talus fracture, they used to put a patient on follow-up. They would get repeated X-rays of the talus done to look for subchondral lucency. Subchondral lucency, this lucency under the cartilage, this subchondral lucency suggests that this talus is viable. Viable means alive. If it becomes dense, it means it would have died. So what is Hawkins sign? Hawkins sign is a good sign. Hawkins sign is a good sign suggesting viability of the talus. What does it show? Subchondral lucency. Okay. Where else did we read Hawkins? Where else did we read Hawkins in the upper limb? Hawkins-Kennedy test, yes, impingement syndrome. Very good, very good. Now, finally, last three fractures that we need to discuss. Chopard's and Lisfranc's fracture. If you recall Chopard's and Lisfranc's, what are these? These are locations. What is Chopard's location? It is intertarsal location between the talus and the navicular, calcaneum and the cuboid. Intertarsal. And what is Lisfranc's? Tarsometatarsal. Metatarsal, okay, between the tarsal bones and the metatarsal bone. That joint is known as Lisfranc joint. So Chopard's joint, Lisfranc joint. What is the significance? If there is a fracture there, we call it with that name. If we do an amputation there, we call it with that name. So Chopard's fracture is done here, intertarsal location, right? We do it there, intertarsal. Chopard's fracture is the fracture of the intertarsal joint. Or if you do an amputation, Chopard's amputation. What is Lisfranc's? Tarsometatarsal fracture. Fracture occurs in the tarsometatarsal region. If you do an amputation there, Lisfranc's amputation. But very importantly, remember Lisfranc's fracture, the characteristic thing that you're looking for is the injury to the Lisfranc's ligament. Now, what is Lisfranc's ligament? Lisfranc's ligament is the ligament that holds the first and the second metatarsal together. This ligament. If this ligament is injured, what happens? The gap between the first and the second metatarsal increases. That's it. Increased gap between the first and the second metatarsal occurs because of the injury to the Lisfranc's ligament. This is known as flex sign. So flex sign is seen in Lisfranc's fracture where there is injury to the Lisfranc ligament leading to diversion between the first and the second metatarsal or increased gap between the first and the second metatarsal. Now, while we are on the topic of the metatarsals, one metatarsal fracture which you should never forget before your exam is Jones fracture or Robert Jones fracture. What is this fracture? It is the fracture of the base of the fifth metatarsal. Where exactly, friends? Because base of the fifth metatarsal is quite large. It is between the fourth and fifth intermetatarsal articulation, this part. So this part fracture, any fracture between this part is known as Jones fracture. Fracture proximal to that is pseudo-Jones fracture. Fracture distal to that is stress fracture. So Jones fracture is fracture of the base of the fifth metatarsal at the fourth, fifth intermetatarsal articulation. Why is it so important that you should know it? Because in this part, there is decreased blood supply because it's in a watershed zone. Blood supply reaches like this. It's in the watershed zone. It has questionable blood supply. So if there is a fracture here, usually it will go into non-union and you should know it. You should pick it up. You should treat it. This is known as Jones fracture. One more important thing, which muscle or tendon comes and inserts the base of the fifth metatarsal causing the avulsion fracture? It is your peroneus brevis tendon. Peroneus brevis tendon. So that is, my friend, your Jones fracture, and this completes everything that we need to discuss in the lower limb trauma. All the way from pelvis, we have reached the base of the fifth metatarsal. Let's practice a few MCQs and see whether we have understood everything or not. The most serious complication of pelvis fracture is a neurogenic shock, hypovolemic shock, rupture of urinary bladder, malunion. Yes, it is hypovolemic shock, and we lose around 1.5 to 2 liters of blood, that is 4 to 8 units of blood. And urinary bladder, no, it's soft tissue injury. Yes, it can occur, but most commonly it's urethral injury. Next, jumper's fracture and open book injuries are seen in forearm, pelvis, femur, humerus. Yes, it's pelvis fractures. These are pelvis fractures. Jumper's fracture is a H or U-shaped sacral fracture seen in jumpers or suicide jumpers. All of the following areas are commonly involved sites in pelvic fracture except pubic rami, yes. Aleophilium, yes. Acetabular, yes. Ischial tuberosities. Ischial tuberosities are considered very strong. Ischial tuberosities are considered very strong, and the fractures of the pelvis very rarely involve the ischial tuberosities. Please keep that in mind. So the correct answer here is ischial tuberosities. Main blood supply to the head of the femur comes from head of the femur, neck, GT, LT, femoral artery, profunda femoris, medial femoral circumflex, lateral femoral circumflex, make a ring, proceed upwards. Predominant sources, medial femoral circumflex artery. Yes, medial femoral circumflex artery. True about Powell's angle is all except between fracture line of the femoral neck and the horizontal plane. Yes, looks true. Increased angle indicates more chances of displacement. Yes, true. Grade 1 is 30 degrees, yes. Second is 30 to 50, and third is more than 50, true. Increase in angle indicates impaction and good prognosis, no. Increase in angle causes displacement. So the answer is D. That is the false statement. Hai na? Right. So if you recall this, angle between the horizontal 30, 50, more than 50. More vertical, more unstable. More unstable. Powell's angle. Which of the following describes grade 2 fractures of the neck of the femur? So they are talking about which classification here? Incomplete, complete, displaced, undisplaced, trabeculae, Gardner's classification. Yes. So grade 2 they are talking about. So grade 2 is displaced or undisplaced. So it's undisplaced. So it is undisplaced. So this cannot be moderate displacement of the neck. It cannot be that. Complete fracture with undisplaced neck. Yes. Complete fracture with undisplaced neck is type 2. Okay. So what was type 1? Undisplaced incomplete. Type 2 was complete undisplaced. Type 3 incompletely displaced. Type 4 completely displaced. Right. So 1 and 2 were undisplaced. 3 and 4 were displaced. Partial, complete. Partial, complete. Okay, na? Know this. So type 1 is incomplete undisplaced. Type 2 complete fracture undisplaced. Type 3 partially displaced. Type 4 completely displaced. And only in type 2 trabecular alignment is maintained. Fractured neck of femur causes which of the following? Flexion at the hip and lateral rotation. Okay. Flexion at the hip and abduction. Okay. Shortening and lateral rotation. Okay. Shortening and flexion. Yes. It causes shortening and external rotation. How much shortening? Neck of femur hai to less than 1 inch. External rotation is less than 45 degrees. This is the answer. A 60-year-old man fell in the bathroom and was unable to stand. Ecchymosis noted on right buttock region with external rotation of the lower limb and foot touching the bed. What is the most probable diagnosis? So fracture hai, hip pe, pain hai, and there is external rotation. Extracapsular fracture neck of femur, probably. Anterior dislocation of hip, no. Intracapsular fracture neck of femur, probably. Posterior dislocation of hip, no. Now between these two, which will you go for? Because it is touching the bed, I will go for intertrochanteric or extracapsular fracture neck of femur. And this is what touching the bed is all about. External rotation. So much so that the lateral part of the touches the couch. Lateral part of the foot touches the couch. An old lady had a history of fall in the bathroom and couldn't move. Her leg was in external rotation. There was tenderness in the Scarpa's triangle and limb movement could not be done due to pain. No hip fracture was noted on X-ray. What is the next step in her management? MRI of hip, repeat X-ray after 1 week, hip joint aspiration, give analgesics and ask her to review after 1 week. Absolutely not. Elderly patient, fall, pain in the hip. It is neck of femur fracture unless proven otherwise. X-ray is negative. Then what will you do? You'll go for MRI. Okay, no need for waiting 1 week. No need of joint aspiration. What rubbish. Okay, MRI of hip. That is what you will do. MRI will pick up hidden or occult fractures. Even if the patient comes to you walking, if there is hip pain, there was a history of trauma, you should assume that it is neck of femur fracture. Now, all of the following can occur as a complication of fracture of the neck of the femur except shortening, yes. Non-union, yes. Malunion. Avascular necrosis, yes. Malunion, no. I've told you in the basics also, fractures that usually undergo malunion rarely undergo non-union. Fractures that usually undergo non-union rarely undergo malunion. Now, treatment of choice for a 1-week-old fractured neck of femur in 65-year-old patient. 65 hai. What will you do? Without even looking at the options, I know I'll do hemiarthroplasty. Hemi replacement arthroplasty, close reduction internal fixation with cannulated cancellous screws. No, I will not fix it. Close reduction of internal fixation, Austin Moore prosthesis. Austin Moore is outdated and there is no close reduction there. It's a replacement. Total hip replacement only if the hip had pre-existing problem. So I will go with a hemi replacement arthroplasty. Best is bipolar prosthesis. If that is not given in the options, then I will go with Austin Moore. Then I'll go with Austin Moore. Okay, so bipolar is much better than Austin Moore. Femoral neck fracture of 4 weeks duration in a young adult should be best treated by which one of the following? So young patient, 4 weeks old. Total hip replacement, no. Young patient hai, no total hip replacement. Prosthetic replacement of femoral head, no replacement. Bhai. There is no need for replacement. Reduction of the fracture and multiple screw fixation, yes, but he's already 4 weeks old. Upper femoral displacement osteotomy, yes. Powell's or McMurray's osteotomy is the thing that you will offer there. Fix the fracture and do the osteotomy. That is the best in the options. A 65-year-old lady presents with 1 week old fractured neck of the femur. She is a known case of bilateral osteoarthritis of the hip. What is the best treatment now? Without doing the options, 65, so you have to go for replacement. Since already osteoarthritis is there, better go for total hip replacement. So answer is total hip replacement. I'm not even reading the other options. McMurray's osteotomy is done for malunited intertrochanteric fracture of the femur. Intertrochanteric, no, it's used for neck of femur. Non-union transcervical neck femur fractures, yes. Non-union lateral condylar fracture of the humerus, no. Malunited supracondylar humerus, no. So this is the answer. But also tell me, what is the osteotomy you will use for malunited supracondylar fracture of humerus? First tell me, what is the malunion in supracondylar humerus fracture? Gunstock deformity, yes. Cubitus varus, yes. What is the osteotomy you will use? Modified French osteotomy, yes, yes. All are true regarding dislocation of hip except posterior dislocation of the hip is commonest, yes, very true. In posterior dislocation of hip, the limb is in flexion, adduction and internal rotation, yes, with shortening also. Sciatic palsy and vascular sign of Narath are noticed in posterior dislocation of hip, yes, true. Posterior dislocation of hip is commonly managed by open reduction under GA. No. Why would you want to open unnecessarily? You can go for close reduction. If it is not reducing, then you can go for close reduction under spinal anesthesia. If that is not going, then you can go for open reduction. Okay. Trendelenburg test or sign is positive due to the injury of superior gluteal nerve, inferior gluteal nerve, obturator nerve, tibial nerve. The answer is very straightforward. Superior gluteal nerve. Superior gluteal nerve, because it supplies the gluteus medius and minimus, which are the principal abductors of the hip. A 30-year-old man met with a road traffic accident and sustained femoral shaft fracture. 2 days later, he becomes mildly confused, develops fever, restlessness, tachypnea and petechial rashes. His chest X-ray shows widespread snowstorm mottling throughout the lung. The most likely diagnosis is, my God, does it get easier than this? A 30-year-old young man, road traffic accident, femur shaft fracture, presents 48 hours later with central nervous system symptoms, respiratory symptoms and cutaneous symptoms. My friends, the answer is fat embolism syndrome. The classical example of muscular violence, strong muscular pull. Fracture fibula, fracture patella, fracture clavicle, all of the above. The answer is fracture patella. Strong pull of muscle causes transverse fracture, and in order to reduce the fracture, you need to convert the distractive forces into compressive forces. So what is the treatment? Open reduction, internal fixation with tension band wiring. Transverse fracture of the patella with the displacement of the fragment is best treated by its open reduction, internal fixation with K wires and tension band technique. That is the best answer. What is the usual mechanism of injury of the lateral condyle of the proximal tibia? What are they talking about? They're talking about bumper fracture. What is the usual mechanism? It is a strain of valgus knee, strain of varus knee, strain of valgus knee with axial loading, rotational injury. Strain of valgus knee with axial loading. Strain of valgus knee with axial loading. No. If you have done sports injuries, let me ask you this one question. So, valgus knee with axial loading, right? Now, if you have done sports injuries, answer this. In bumper fracture, which ligament will get torn? This one, which is medial collateral ligament. Yes, because of the valgus force. Next, the most commonly affected component of the lateral collateral ligament complex in an ankle sprain is. In an ankle sprain, among the lateral collateral ligaments, which is the most commonly injured? Middle component, anterior component, posterior component, deeper component. Answer is anterior talofibular, so anterior component. True about eponymous fractures are all except. Monteggia fracture is a fracture of the proximal third of ulna with radial head dislocation. Remind yourself from upper limb trauma. Yes, this is true. Galeazzi fracture is the fracture of the distal third of the radius with dislocation of the distal radioulnar joint and injury to the TFCC. Yes, true. Colles fracture is the fracture at the corticocancellous junction of the distal end of the radius with dorsal tilt. Yes, osteoporotic females. Potts fracture is a trimalleolar ankle fracture. Potts is bimalleolar. Cottons is trimalleolar. Bennett's fracture is oblique intra-articular fracture of the base of the first metacarpal. Yes, Bennett and Rolando are fractures of the base of the first metacarpal. Intra-articular. Bennett's is incomplete displaced fracture. Rolando is complete undisplaced fracture. Yes, so the answer here is D. This is the wrong statement. Which of the following is a false statement? Cotton's fracture is trimalleolar. True. Potts fracture involves both malleoli. True. Lisfranc's is tarsometatarsal dislocation. Yes. Chopart's is intertarsal. True. Jefferson's is C2 fracture. No. Jefferson's is C1 fracture. Very good. Pilon fracture is bimalleolar, trimalleolar, distal femur intraarticular, distal tibia intraarticular. You know this. Distal tibia intraarticular. Yes. This is the answer. The attitude of limb in posterior dislocation of the hip joint is. Tell me, you don't have to read the options. Flexion, adduction, internal rotation with limb shortening, and the head of the femur will be palpable in the gluteal region. So look for flexion, adduction, internal rotation with limb shortening. That is the answer. Okay. Now in the figure given below, the abnormality can be explained by weakness of. So this is the abnormality that is happening here. Okay. So this pelvis is sinking down. Okay. He's telling it can be explained by 2 gluteus medius, 2 gluteus maximus, 1 gluteus medius, 1 gluteus maximus. So this is side number 1. This is side number 2. So what is the problem here? What is the abnormality here? The sound side is sinking. So 2 is sinking. So this is the sound side is sinking. Which is the pathological side? This is the positive pathological side. Okay. So what could be the problem on side 1? Side 1, it is gluteus medius or gluteus maximus? It should be gluteus medius. That is the problem. Yes, gluteus medius. So 1 gluteus medius. This is the correct answer. This is the pathological side. Because of this, the abductor is failed and the opposite side is sinking down. Okay. Now, where will the patient lurch? Where will he lurch? He will lurch towards 1. He will lurch towards the pathological side. Okay, sound side sinks. Please remember that. Now, what is the likely diagnosis of injury to the left lower limb? So this is the left lower limb. What is the injury here? A posterior dislocation of hip, anterior dislocation of hip, fracture shaft of femur, fracture neck of femur. The attitude is there is flexion at the hip, there is adduction of the thigh, and there is internal rotation. So flexion, adduction, internal rotation, friends. So what is it? It is a posterior dislocation of hip. Next, a patient was brought to the hospital with complaints of pain around the left hip joint following an RTM. On examination, the affected limb was flexed, adducted, and medially rotated with obvious shortening. What is the most likely diagnosis? Come on, you know this. The answer is posterior dislocation. A 15-year-old boy was brought to the emergency room following a motor vehicle collision, complaining of pain over the hip. X-ray is given below. What is the next step of management? X-ray is given below. Okay, so this is your Shenton's line. It looks good. Shenton's line broken. Dislocation, adduction, and internal rotation. So it's a posterior dislocation of hip. So what is the next line in management? Do a close reduction and assessment of hip stability. Looks like a good option. CT and 3D reconstruction. Why? Your diagnosis is clear now. Why unnecessary get a CT scan? Are you getting kickbacks? High weight skeletal traction. Skeletal traction will not help now. You reduce and then you can apply skeletal traction to prevent recurrence. Open reduction and posterior pillar of acetabulum reconstruction. There isn't any fracture now. Why would you want to reconstruct anything? The correct answer is close reduction and assessment of hip stability. Right? And once you have reduced it, you apply skin traction, skeletal traction to allow the soft tissue to heal. Around it. Which of the position of hip is being tested in the picture given below? Basically, the question is asking which position of hip is being tested in the picture given below. Which position of hip? Is it internal rotation, external rotation, abduction, or flexion? Obviously, there is flexion at the hip, but the examiner is turning the leg in. So basically what is he testing? He's testing the external rotation. He's testing the external rotation. Please remember this very important point. When you're rotating the leg, you're basically trying to do internal or external rotation for the hip when the hip and knee are flexed. So please look at this. When you're bringing the leg out, you're basically doing internal rotation at the hip, and when you're sending the leg in, you're basically doing external rotation at the hip. So don't get confused on the exam. Don't get confused on the exam. Don't get confused on the exam. Here we are doing internal rotation. Here we are doing external rotation. Now with that, we have basically completed our lower limb trauma. It's essential that you practice a lot of MCQs here, particularly from dislocations of hip and fractures around the hip. That way you will be sure that whatever you have learned now, you'll be able to answer on the exam.